Now also it's showing as you are in a practice session.
The webinar is now streaming live on custom live streaming service.
Yes, that's coming.
Started the webinar. There are 10 participants.
Oh, okay. $16 now. Oh,
Yeah.
that is.
It's a good number for our.
She just now only opened it. Oh,
Yeah, that's it. 20, 21. So, Dr. Sunil, I think I'm going to start it because it's already 7.
Yes.
Good evening, everybody, and welcome to this first Journal Club of 2023. And wish you all a happy new year from the stroke subsection of Indian Academy of Neurology. And for today's proceedings, I'll hand over the chair to Dr. Sunil Narayan to conduct along with Dr. Menka. And sir, Dr. Sunil, please take over and conduct this session.
Hi, we have the speaker, the presenter, Dr. Yuvraj and Dr. Menka already joined in. Dr. Yuvraj, I can see.
Yes, sir.
Dr. Menka, have you got access?
Yeah, she joined.
All right, okay.
She's in participants.
Okay, she's using that one. She has been given a direct link also, I don't know. Maybe she's trying that. So thank you very much. I join Dr. Koti, the convener of the subsection of the Indian stroke subsection of Indian Academy of Neurology. Hi, Dr. Menka. Yes. So this is the first of our regular monthly programs for the year 2023. And we conduct this on every month on the first Monday of the week. This is the second Monday because everyone was busy with the holidays towards the end of the last month. So we have taken the liberty to extend it to the second week. And we have had this program going on with a lot of interest and very good academic discussions on papers for the last, I think it should be around 6 months now, Dr. Koti?
No, it's almost 8 months. Sir.
8 months. So we have had around, except the month of Indian Academy of Neurology's national meet, we had programs every month. And so today again, we have an extremely interesting topic. We all know the interested in this made in India thrombolytic drug, the tenecteplase, which is of course being marketed elsewhere outside India as well. And this is a study of tenecteplase in various European countries as well as in New Zealand. And they were looked at the effects of using tenecteplase in wake-up strokes with only the non-contrast CT imaging and try to see how safe it is and how effective it is. And paper is published just recently in December 2022 only in Lancet. And to take us through this interesting paper, today we have a very competent academic team where we have the team from the All India Institute of Medical Sciences, Bhubaneswar, is presenting the paper today. Dr. Menka Joy is the additional professor or associate? Menka?
Professor.
Yeah. So, Dr. Menka, we had the pleasure of having her with us before she joined for DM at Nimans, Bangalore. And then she went on to join as faculty at AIMS Bhubaneswar. And along with her is her colleague, Dr. Priyanka Samal, faculty at AIMS. And we have, of course, the head of the department of neurology at AIMS Bhubaneswar, Dr. Sanjeev Boy. Good evening, Dr. Sanjeev. We can't see you.
Good evening, sir.
Sanjeev. Right.
Good.
Yeah.
Thank you, sir.
Nice to see you. So the presenter today is Yuvraj Lahiri, and I understand Dr. Sanjeev also has a special interest in stroke. So Dr. Sanjeev, I will now hand over the proceedings to you and Dr. Menka and to your presenter student. Thank you.
Thank you, sir. Good evening, sir. Sir, at the outset, we thank the IN, the President Secretary, and the subsection chair, sir, Professor Sunil Narayan, sir, and Professor Dr. Gothri. Actually, Gothri, sir, we met regularly met during the SGPGI club, there the academic discussion during his stay at Lucknow, sir, that Command Hospital.
Nice. Thank you.
Yes, sir. So today, the Dr. Yuvraj, our currently final year resident, will discuss the journal club recently published in the Lancet Neurology. So this is an interesting topic. Can we extrapolate this knowledge in our resource poor setting? And with us, our panelists, other moderators are Dr. Menka and Dr. Priyanka. So Dr. Menka, can you brief? Thank you, sir.
Thank you, sir. At the onset, I would like to thank IIN team, and I'm very grateful to Dr. Sunil Narayan, sir. He was the first mentor, my neurology first residency before my DM started there only. So I'm very grateful to sir to give us the opportunity to present the journal club. And I would like to, because this is the this year's first journal club, so I'd like to wish everybody a very happy new year. So today's topic chosen is regarding the wake-up stroke. So as the current guidelines recommend altiplase in the wake-up stroke, but it is based on the imaging, MRI imaging, diffusion, perfusion, diffusion and flare mismatch, as was in the wake-up trial, and also in the perfusion mismatch by either CT perfusion or MR perfusion. So this is the standard guideline. But as we all know that this availability of the MRI round the clock is difficult in the emergency setting. It is not available always. And also the perfusion imaging interpretation, that is also an expert thing. That is also the availability might be an issue. So the current trials, that it was based on the non-contrast CT, which is widely available at all the stroke centers. And the drug uses tenecteplase, though the guideline recommends altiplase. But as we all know that tenecteplase is now becoming the choice among all the stroke physicians. It is rapidly being used because of the longer half-life, ease of administration, and fibrin specificity is better. So this has become the drug of choice, and also the imaging criteria is different from the previous recommended guideline. So it would be better if a larger group of the wake-up stroke patients are being selected, because might be the lack of availability or not always the diffusion perfusion mismatch is available. So some portion of the wake-up strokes might be prevented from getting the reperfusion therapy, which is the standard of care. So let's discuss the current topic. Safety and efficacy of tenecteplase in patients with wake-up stroke assessed by non-contrast CT twist trial. Which is a multi-center, open-label, randomized control trial. So I would like to hand over to Dr. Yuvraj, who is our DM final year resident, who is going to present. Over to Yuvraj.
Okay. Good evening to all respected delegates, respected teachers. Are my slide visible?
Yeah, right now, yes.
Okay. So first of all, I would like to thank the IN Stroke Subsection for giving me opportunity to present article in Journal Club. We are here to discuss this twist trial, which was published in December 22 in the this Lancet Neurology. So it is a safety and efficacy of tenecteplase in patient with wake-up stroke assessed by non-contrast CT. So in the trials in past 5 years have supported the use of IV thrombolysis with the tenecteplase in patient with ischemic stroke of unknown time of onset who would have this diffusion flare mismatch or salvageable tissue on the CT or MR perfusion imaging. And this treatment with IV alteplase is currently recommended in clinical guideline. So we can see that currently we follow this guideline that if patient with wake-up stroke or with unknown time of onset, if they comes, then we generally do a diffusion and flare MRI brain. And if there is mismatch between the diffusion and flare, then we go for thrombolysis in these patients. But this MRI have limited access. All the stroke centers or all the centers in many countries do not have facility of this MRI. Also in the countries where hospitals where this MRI facility is available, and mostly during night time, only in the few hospitals we will get this facility of MRI. And other than this, this diffusion flare mismatch can be absent in nearly 40% of patients with known duration of stroke of less than 3 hours. Other than this, we also know that this thrombolysis is underused. Only 2 to 12% of patients with acute ischemic stroke patient undergo IV thrombolysis. And of those, 2/3 of patients, there is more than 60 minutes of time in the door to needed. And for this, the problem are either delayed arrival, non-availability of RTPA, or in-hospital delays beyond the time of eligibility. And other than this, this prolonged timing imaging. On average, CT scan will be done in the 5 minutes, but MRI, it requires almost around 20 minutes. So this timing will be changed, this time will be managed if we decide whether to give thrombolysis based on this NCCT alone. So coming to the molecule, this tenecteplase is a genetically modified tissue of alteplase with the 3-point mutation, threonine replaced by asparagine. Asparagine at 117 level replaced by glutamine, and the 4 amino acid lysine, histidine, and 2 arginine replaced by the alanine. And this drug is approved by DCGI in the July 2016. And coming to the difference between the alteplase and tenecteplase, we know that this alteplase is a recombinant version of naturally occurring tissue plasminogen activator, while this tenecteplase is a bioengineered variant of this tissue plasminogen activator. And this tenecteplase is more fibrin specific, that is 14-fold more specific than the alteplase. And also it is more resistant to degradation by this endogenous plasminogen activator inhibitor. And then the half-life of this alteplase is 5 minutes, whereas for tenecteplase it is 20 to 24 minutes. And the preparation of this alteplase is more complex, require more time, and also in the administration it requires almost 60 minutes. But in the tenecteplase, preparation is simple, and also it can be given IV bolus in 5 to 10 seconds. So there are multiple trials comparing this efficacy and safety of these two drugs. Like one, this RCT of tenecteplase versus alteplase with patient of 75 patient. They saw that tenecteplase was associated with better reperfusion and better clinical outcomes. Then the Extend 1A trial, they saw that tenecteplase before thrombectomy has higher incidence of reperfusion. Then this extend 1 TNK part 2. This was this compared a dose of this tenecteplase 0.4 mg per kg versus 0.25 mg per kg. The findings suggest that these two drugs do the higher dose do not confer any extra advantage over the lower dose. And then the Nortis trial, they showed that tenecteplase was superior to erteplase and showed similar safety profile. Also, this Nortis 2 has been recently published that has also shown that this difference of between the two doses, that 0.4 mg per kg versus 0.25 mg per kg were almost similar. And this is the meta-analysis of all 5 randomized trial. They have concluded that this tenecteplase is non-inferior to erteplase in treatment with this patient with acute ischemic stroke. So coming to the wake-up stroke, this wake-up trial is the first RCT in a patient with wake-up stroke. And here total number of patients they have chosen was 503, and they included all patients with wake-up stroke or unknown time of onset who had this diffusion and flare mismatch in the MRI. And they excluded all patients who were planned for thrombectomy or having this NIHS score of more than 25. And in this trial, the mean age of patient were 65 years. Although the trial was terminated early due to cessation of funding, but they showed that there was significantly better functional outcome and numerically more ICH in patient treated with the erteplase than the placebo patient. But here, 2/3 of patients were excluded mainly due to absence of diffusion flare mismatch. Then this is the meta-analysis of 3 trials: this extend trial, ECAS-4 trial, and epithet trial. Here also they used CT perfusion or MR perfusion in patient with stroke onset of 4.5 to 9 hours. And here also they showed that this patient treated with erteplase have better functional outcome than the placebo, although the symptomatic ICH were higher in the erteplase group. And this is the forest plot of this meta-analysis. Here we can see that in the all age group and all trials slightly favoring, but although non-significant, slightly favoring more in the erteplase group. And in those with NIHS less than 10, it was more favorable. And also in the some Asian population, although sample size is low, it is more favorable. And in this epithet trial, there were more favorable patient with the treatment with the erteplase, although here also the sample size was low. So this NCCT is widely available in stroke center, although it has low sensitivity for quantification of infarct core compared to the DWI or CT perfusion, and it might compromise safety if used for patient with wake-up stroke to select thrombolytic treatment. But this NCCT have been shown to be safe in 2 prospective single-arm open-label trials. These are the 2 trials of this. First is this prospective open-label safety study of IV recombinant tissue plasminogen activator in wake-up stroke. Here they have taken 40 patients with mean age of 60.8 and median NIHS score of 6.5. And here this PA was given within 3 hours of awakening. And here also they have chosen a patient based on the non-contrast CT. And though they showed that at the 3-month, 20 of 38 patients achieved excellent recovery. And though no symptomatic ICH or parenchymal hematoma occurred. And this is another trial published in May 2018. Here they studied in 20 patients with the erteplase. And here also the average age was 65, and they selected patient based on NCCT alone. And this stroke symptoms of within 4.5 hours of awakening. In this, they concluded that the NCCT would be feasible and will be maybe safe in this wake-up stroke patients. So coming to this study, why this study? So this study is can show us whether this tenecteplase in wake-up stroke will be beneficial And also whether this in the wake-up stroke we can select patient based on the this NCCT alone, or also we will assess whether there is increased risk for intracranial hemorrhage, systemic hemorrhage, any neurological deterioration or death with the use of tenecteplase in patient selected with in patient of wake-up stroke selected with NCCT alone. So coming to the research question, here this population on patient is it more than 18 years with acute ischemic wake-up stroke were included, and this NIHS score should either be 3 or more than 3. In NCCT should not have any exclusion criteria like bleeding or any mass or other contraindication. And intervention was this tenecteplase 0.25 mg per kg plus best standard care. And in the control group, they gave only the best standard care. And this primary outcome were MRS at 90 days, and there were multiple secondary outcomes like excellent functional outcome, good functional outcome, and response to treatment according to neurological deficit that I will also discuss later. So coming to the study design, it was an investigator-initiated study conducted at multi-center, 77.
I think there were some safety parameters also in the outcome.
Yes, sir, there were safety parameters. I will show that on the later slides, sir. I will come to that. So it was conducted in 77 hospitals in 10 countries and was an open-label trial, a randomized controlled trial. It was open level, but this endpoint assessment were blinded. And also there were multiple committees like this trial steering committee who design and supervise the trial, help in development and amendment of protocol. Then event adjudication committee for adjudicating this primary efficacy, secondary efficacy outcome, any bleeding events. Then data monitoring committee for progress of trial, regular assessment of safety outcomes. Also, there was imaging scientific committee who independently assess the imaging and help in the randomization of patients. And this study, received the funding from this Norwegian Ministry of Health and Care Service, the British Heart Foundation, Swiss Heart Foundation, and although there was no direct pharma company involved in the funding, this Boehringer company was supposed to refund the cost of tenecteplase after the completion of trial. So coming to sample size calculation, first they estimated a sample size of 500 based on a systematic review, but in between this result of this wake-up trial was published that show the difference between patient who received thrombolysis and those who did not receive of 11.5% for a favorable outcome. So based on this, they assumed a clinical relevant treatment effect with odds ratio of 1.50, corresponding to absolute difference of 10%, and the proportion of patient achieving MRS 0 to 1 at 90 days. So they finally decide this sample size of 6% with 80% power and significance level of 0.05.
If I can interrupt for a minute, we are joined by Professor Kameshu Prasad, who is today's expert. He's an expert in tenecteplase as well as in research methodology.
Thank you. I'm listening for last 10 minutes, 5 minutes maybe.
Sir, you have any specific comments on the
no, let him
sample size at this point?
No. Let him complete, then we will.
Okay. Please go ahead.
Okay. So, primary null hypothesis here would be in patient with wake-up stroke selected with help of NCCT brain. Thrombolytic treatment with tenecteplase will have same functional outcome at 3 months as in those treated with standard care alone. And alternate hypothesis would be in patient with wake-up stroke selected with help of NCCT brain. This thrombolytic treatment with tenecteplase will reduce the risk of poor functional outcome at 3 months compared to those treated with the standard care alone. So coming to inclusion criteria, patient with symptom of stroke on awakening were included, and those with those patients should have an NIHS score of either 3 or more than 3 or dysphagia. And a patient should have this feasibility of tenective place within 4.5 hours of awakening. And there were multiple exclusion criteria, of which this age less than 18, an NIHS score of more than 25, or any finding in the pain CT like bleed or any mass, or also they have said that this infarct should not be extending more than 1/3 of MCA territory. And this apart from this, any internal bleeding or high risk of bleeding, and other multiple contraindication like exclusion, like contraindication to tenective place, persistent high blood pressure, low blood glucose, pregnancy, or other serious or life-threatening disease like MMSC of less than 20 and MRS of more than or equal to 3. And also, if the patient is non-available for follow-up, they have excluded. So the local principal investigator or treating physician enrolled the patient into the trial, and based upon the central web-based computer-generated randomization schedule. And this schedule also had used minimization algorithm that balanced the age, whether they were younger than 8 years or older, this NIHS severity, whether this NIHS of less than 15 or more than 15, and time since wake up, whether less than 3 hours or more than 3 hours. Then coming to the procedure, so after selection of patient were randomized either to this tenective place arm, 0.25 mg per kg plus base standard care or standard care alone. And on this baseline, this NCCT along with and CT angio was also done, and this clinical assessment was done. And on the day 2, this repeat NCCT was done. And on the days patient was discharged on the day 7 or the discharge, whichever occurred earlier, the second clinical assessment was done. And on the this 90 days, this telephonic interview was done. And also here we can see this thrombectomy was allowed in both treatment groups. This is another table indicating the same timeline. So we can see that this repeat CT angio was done only if the first CT angio was showing any positive finding. So we can see the same thing, that CT angio or perfusion at admission was recommended in protocol but was not mandatory, and repeated within 24 hours of admission in patient with large vessel occlusion. Although not a part of study protocol, supplemental brain MRI or perfusion was also allowed, and they were discouraged if it was delaying the random assignment by more than 20 minutes. So this outcomes, like discussed earlier, primary outcome was MRS at 90 days. Then secondary outcome, first is this excellent functional outcome, that was the patient with MRS of 0 to 1. Good functional outcome with MRS 0 to 2, and then response to treatment according to neurological deficit at study entry point, that is MRS 0 for patient with mild deficit of NIHS less than or equal to 7, the MRS 0 to 1 for patient with moderate deficit, and MRS 0 to 2 for patient with severe deficit. And other secondary outcomes were this Euro quality of life score, MMSC, then Barthel index score at 90 days. And these were the safety outcomes: death from all cause at 90 days, symptomatic ICH at day 7, parenchymal hemorrhage type 2, any intracranial hemorrhage, or any other major extracranial bleeding. So analysis part, this discrete variable were summarized as frequency and percentage, continuous variable is mean and median, and time interval is median, and difference in outcome between two treatment groups were tested independently at 0.5 0.05 significance level, and estimate of treatment effect are presented in 95% confidence interval. And the primary outcome analysis was done using ordinal logistic regression and presented at odds ratio with 95% confidence interval. And secondary and safety outcome were compared between treatment groups using binary logistic regression for dichomatous outcome to estimate odds ratio with 95% confidence interval. And also this Cox proportional hazard regression was used to calculate hazard ratio with 95% confidence interval for death during follow-up. So coming to the consort diagram, this we can see 578 patients were enrolled first, of which 288 in that this tenecteplase place arm and 290 in the standard care arm. But of the 288, 5 patients in that this tenecteplase place arm did not receive thrombolysis. And this of this they have given reason that 2 patients improved spontaneously, and 1 due to new direct oral anticoagulant intakes, 1 due to revised diagnosis, and 1 due to resistant hypertension. And in the standard care group, this 6 patients received thrombolysis, of which 1 with the tenecteplase and 5 with the this alteplase. So after this, 283 received assigned treatment, and 284 in the control arm received the assigned treatment. Of this, 8 patients lost to follow-up before 90 days in each group. And for the final per protocol analysis, 283 patients were included in the treatment arm and 284 in the control arm. And coming to the baseline characters, so this mean age, distribution of patient based on age group, sex, and country-wise, all were almost similar in each group. And this diagnosis at discharge were almost also similar in each group. Only this stroke mimic were 4% in this treatment arm and 6% in the control group. And among the risk factors, this atrial fibrillation was comparatively more, that is 21%, and 11% in the control group. And other like this hypertension, diabetes, smoker, coronary artery disease, other risk factors were equally distributed in the both groups. And then this pre-morbid MRI score, median NIHS, and distribution based on this NIHS, all were and median aspect and aspect score distribution were almost similar. Although we can see that here some patients were in the low aspect group also, like 6 to 7, here 10, 22, 0 to 5, 7, and 4. And then this large vessel occlusion was slightly more percentage of patient in the control group, and those who were undergone this endovascular treatment were also more in number in the control group. And this other parameters like time from onset to last known to be well for random assignment in minutes were equal. Time from wake up to the hospital admission were also equal in both group, and time from wake up to random assignment and time from hospital arrival to start of thrombolysis, this were given. Then coming to the result part, so they said that this tenecteplase was not associated with a better functional outcome according to MRS score at 90 days with adjusted odds ratio of 1.18. And in this table, we can see this patients with different MRS score in each group. Like in the 14% in the tenecteplase group, 11% in the control group, and 31% here and in the treatment, and 27 in the MRS1 category. And in the other as well, we have given almost a similar number of patients in each group. And this is the forest plots of sub-analysis, subgroup of the patient. And here, like in the all age groups, slightly this tenecteplase was slightly better, although non-significant. And in the atrial fibrillation, we can see that the patient who were not having atrial fibrillation, they were having more favorable outcome with the tenecteplase compared to those who were having the atrial fibrillation. So this median score on MRS was 2 in both treatment group, and the proportion of patient with excellent functional outcome was 130, that is 45% in tenecteplase group and 38% in the control group. And the proportion of patient with good functional outcome did not differ. It was also 61% in the tenecteplase and 60% in the control group. we can see this the secondary functional outcome, that is excellent functional outcome 130 here 45% and 38%, only a difference of 7%. And good functional outcome almost similar 61%, 60%. And response to treatment according to baseline also 24% and 19%. And this is a distribution of MRS score in each treatment group at 90 days follow-up. We can see that in the zero MRS group, slightly 3% more in the tenecteplase arm, and here also 4% more in the this tenecteplase arm. And there was in the other MRS group almost similar number of patients were there. So response to treatment according to neurological deficit was similar between groups, and median score on MMSE Barthel index and quality of life index were similar at 90 days, and the NIHS score at 24 hours and 7 days, and median changes in NIHS from baseline to 24 hours and 7 days were also similar between the groups. And coming to the adverse event, here this death was 10% in the tenecteplase group and 8% in the control group. And a serious adverse event here 82 in number and 70. And others like this symptomatic intracranial hemorrhage are slightly more in number 12 and 8. And based on this seats most definition, it's 6 and 3. And this others were almost similar in each group. And this is the Kaplan-Meier plot for cumulative risk of death in each treatment group. Here also no significant difference was there, although this line is slightly above in the tenecteplase, but hazard ratio is only of 1.29. So coming to the discussion, this the primary endpoint analysis did not show better functional outcome, and the wake-up trial, which was the first RCT, showed the benefit from thrombolytic treatment with the tenecteplase. And these three trials, Extend, THOS, and ECAS-4, that were terminated early, but positive effect was shown in the Extend trial. And here we got the difference of 7% between the excellent functional outcome at 90 days, which is similar to meta-analysis of patient who received treatment within 3 to 4.5 hours of non-symptom onset. And also similar to individual participant meta-analysis of this wake-up, THOS, and Extend and ECAS-4 trial. And there was no difference in the mortality between 90 days, but compared to the wake-up trial, this in the excellent functional outcome, here we can see this in the this twist trial, there was 45% this excellent functional outcome, that is MRS 0 to 1, and in the wake-up it was 53%. So comparing these two, the p-value was 0.7. And for symptomatic ICH, in the twist trial, it was also 0.02%, and in wake-up also 0.02% with p-value of 1. And in the death, if we compare here, we will it will look like there were more this death in the this both in tenecteplase group and the control group in the this twist trial. Compared to the wake-up, here it is 10%, here 4% in the this treatment group, and 8% and 3% in the this control group. And the p-value for this here it will be 0.02. But on comparing this two, in the wake-up trial, all the patients were comparatively 8 years more younger than the patients in the twist trial. Also here more number of A patient in the intervention in the twist trial. And we all know that this A patient generally have worse this outcome, and also have more chances of this recurrent stroke. And also in the twist trial, some patients were on anticoagulation, and this thrombectomy was allowed in the twist trial, which was not allowed in the wake-up trial. And in this twist trial, some patients were also in the low aspect group, that is on a low aspect that is below the 7, but these were not in the wake-up trial. Also, this more ICH in the tenectic groups is reported numerically more in our trial, this trial, that is similar to previous trial in patient with known symptom onset. And this symptomatic ICH are less frequent in mild stroke in both treatment groups, and it is similar to combined result of this four trial, like wake up trial, THOS trial, and extend and ICAS 4 trial. So they said they give these are the others limitation. They said that the revised estimate assumed a treatment effect of 10% absolute difference, and this requirement target based on that was increased from 500 to 600. And considering the result, the estimated treatment effect was too optimistic, and consequently the trial was underpowered. And for the less inclusion, they have shared that during that time this COVID-19 pandemic was there. And also in 2021, there was a shortage of tenective place. And they concluded that this tenective place was not associated with better functional outcome in patient with wake-up stroke at 90 days. And number of symptomatic ICH were more in this treatment arm. So they concluded that this evidence does not support treatment with the tenective place in the selected patient selected with the non-contrast CT. So coming to the critical review part. First, did this trial address a clear question? So yes, it addressed a clear question whether this patient with wake-up stroke selected based on the NCCT alone will have a better functional outcome with the tenective place or not. And was the assignment randomized? Yes, the assignment was randomized based on computer generated number. Then were all patients properly accounted for its conclusion? There were some dropouts before the follow-up at the 90 days. And this trial was not blinded. It was open label, but there was blinded in-point assessment. Then were the group similar at the start of trial? So it's no, there was a significant difference in the baseline. There was in the more number of patient of atrial fibrillation in the this treatment arm, which would significantly impair this result of this trial. And also this other factor like a low aspect score, and also some patients were on anticoagulation that were almost equal in both of the groups. And where the groups treated equally, we cannot say is it was an open label trial. So after allocation of this treatment or this standard care, we cannot say whether they were treated equally or not. And how large is the treatment effect? So this odds ratio was of 1.18 with the confidence interval between 0.8 to 1.58. And are the findings relevant to the scenario? Yes, if the trial result would have been this in favor of this tenective place, we could have applied it to the general population. So where all the clinically outcomes were considered, yes, all the clinically outcomes were considered, like all primary and secondary outcomes. And here we did not get any benefit with the result. So we can say that we should give a new trial after elimination of factors like this atrial fibrillation in each group, anticoagulation, and the patient with low aspect score. Also, we can do this trial with a double blinding, and this trial in the Asian population or in the our countries, including the patient of our country. So this is the summary of this critical review, method assessment and this all extrapolation. Yes.
Thank you, Dr. Yuvraj. You have done a quite decent work of comprehensively covering right from the background of the study and taking us through the relevance of the study and the study methodology, and also into the results and the analysis. So let us hear about comments from first from the mentors. Dr. Sanjay and Dr. Menka, you have any comments to make before I try to open to other people, and then experts' comments from Professor Prasad? Would you like to give any of your comments overall? Hello. Dr. Menaka, Dr. Sanjeev, any comments?
Yes, sir. So this was a negative trial, though it was published in Lancet Neurology. But the result what they have concluded was the odds ratio of 1.5, the difference would be there with a 10% absolute difference. And the trial reached up to 7% after the adjusting the new sample size after that wake-up trial result. So there are certain intricacy of this trial that already Yuvraj has said. The arms that were selected, the atrial fibrillation were more in the one arm, the trial arm as compared to the control arm. Secondly, they are on oral anticoagulation therapy, so that will have the poor outcome in case of thrombolysis. Secondly, they have taken severe stroke also with a aspect score less than 5. So by the definition, they have said that they will not take severe stroke, but they have included the severe stroke around odds of around 20% in each the arm. So, and after randomization to the trial with a plain CT scan, either they have given the active drug, that is the tenecteplase 0.25, or the best treatment. They have gone for a thrombectomy also. So sometimes the thrombectomy, the procedure, they have an inherent complication that will result in the poor outcome. So that things should be nullified before telling that the TNK is not useful in case of non-contrast CT scan, because this will have a more positive outcome in the resource poor setting if this trial would have been a positive result. So with the elimination of this limiting factor, if the new trial can be taken up with our ethnicity, the Asian population, that will show some positive result. And the meta-analysis of the trial also said that the Asian population, they have in wake-up trial, they have more positive response as compared to the European or the American population. So further trial is required before negating this trial as there is no improvement in the trial, sir. Sir, over to you, sir.
Yeah, I have just a couple of questions, just thinking aloud, like the fact that around 46 patients in the control group had endovascular therapies. And considering the fact that many of these patients are, though wake up must be beyond the window of thrombolysis, looking purely from that point of view, it's the fact that the control groups had more of thrombectomy is something which is more favorable treatment of the control group. So whether that would have any way tilted the probability of having any superior effect that are in place towards a neutral, no difference kind of situation. But at the same time, we also see that despite the fact that a major intervention procedure like endovascular therapy was done more in the control group, the mortality is much higher in the tenecteplase group rather than the control group.
Yes, sir.
So the so that's also intriguing. So despite with less intervention procedures and all, we have had higher mortality in the
Active arm.
technically
Yes.
active place group. So how do you explain? How do you analyze this?
Yes, sir. For this, we compared this with the patient with the wake-up stroke, sir. So probably we are getting more number of more aged patients, like patient around 80 years, and also this atrial fibrillation was more. And here some patient were also on anticoagulation. So after giving this patient, thrombolizing this patient, probably they would have more bleed and more chances of this poor functional outcome.
So generally, compared to the wake-up trial, TWIST trial certainly had a worse outcome, relatively worse outcome compared. So, which also means that the use of MR imaging and other selection procedures, looking at the diffusion perfusion mismatch and more selective recruitment of the patients. That has helped improve the mortality, or that has, and the absence of that, and using only CT scan has slightly worked against the thrombolysis in the wake-up patients in the TWIST trial. Correct? Am I
No,
right?
Dr. Sunil,
Yes, please.
my first, because this type of comparison is dangerous.
No, I am just
The
Yes.
the fact that I don't know whether paper has done it or our presenter has done it. Has the paper, perhaps the paper has done it, isn't it?
No, sir. This comparison is done by ourselves, sir. We have compared the wake-up data and the TWIST data, and the best outcome we have taken both the patient. Yes,
so this is a warning that this type of comparison is not to be done, right?
Yes, sir.
This is called between study comparison. So between two studies, you can compare only if patients are similar, right? And how will you know whether patients are similar or not similar between the two studies in the two arms? Very good, you can say, marker of severity is mortality rate. You see, if the patients have severe stroke, no matter what you do, there will be more mortality in those studies where there will be more severe stroke. So you have seen that in the TWIST trial, mortality is more 8 to 10% compared to 1 to 4% in wake-up trial.
Yes.
That is a very good confirmation that the trial conducted in TWIST consists of sicker patients than the trial which was done for patients in the wake-up trial. So these two are very different group. I think this is a good example where I will use it to illustrate why studies between study comparison is dangerous. And you have rightly pointed out the age difference also, I think, isn't it? Did you say that?
Yes, sir. Age
They
difference
are
was there.
8 years younger in wake-up trial. So I am 100% sure if you do a study in India, you have seen what is the average age of the patients. Average age is 73 years.
About 70.
Average age in the randomized trial, if you take overall patients, is 73 point something, isn't it?
Yes, sir.
Yeah.
If you do it in India, what will be the average age of our patients?
At least 10 years. 10 years younger,
Yeah,
sir.
it will be 56, 57 years, right? So certainly between 55 and 60 years. Therefore, we will have much less mortality than TWIST trial or even wake-up trial. because our patients are younger. If you do same criteria, same inclusion exclusion criteria, still you will have less mortality, because age is a very strong determinant of mortality. We know that, isn't it? So between study comparison should not be done unless you are sure that they have. When can you do it? You can do it in a meta-analysis, but then you will find heterogeneity, and then you will have to explain heterogeneity, and explanation of heterogeneity will be that this trial has different result because that is conducted on sicker patients. These are better patients. So those type of explanations will come in meta-analysis, and even meta-analysis says that if there is too much difference in results, then you should not combine it. So that is one thing, is that this between study comparison is fraught with danger. We should avoid doing it as far as possible to derive any conclusion. Just for the sake of illustration, you did a good thing, and I'm going to use this to illustrate why between study comparison should not be done, because type of patients are different. That is one point. So I think
so which factor must have made this mortality higher? Is it age
one is
alone, or something other things as
no,
well?
no,
Selection mode, does it come into that, or it's
one is age. Age is one clear cut. Secondly, if we look at the whole or let's say mean NIHSS, I don't know whether they have given mean NIHSS or not. And the atrial fibrillation is also one of the factors which is not a cause but association with increased mortality, and that may be one reason. But we have to look at details of all the factors which are associated with mortality, which is severity of stroke, comorbidity. We have to compare what proportion had hypertension, diabetes, etc., etc. And then, of course, age is very important. Comorbidity includes atrial fibrillation. So all of these things, renal failure or no renal failure, or renal impairment, no renal impairment, even electrolytes, we have to check so many things which are associated with mortality. But that we can forget about this comparison, but let us come to the study. When we do critical appraisal,
Yes.
First thing is, we often say that, of course, after you have looked at randomization and usually whether it is concealed randomization or not, this is concealed randomization, so a computer-based randomization. But the next point comes, are the baseline prognostic characteristics similar or not? Right? And there, I think you did a good job. You pointed out that atrial fibrillation, large vessel occlusion, and I think these are the two things, and therefore rate of thrombectomy also was different in the two groups, right? That these are the three main. If I'm forgetting something, please remind me, right? So when you determine this, I always say that ask yourself which group is being favored because of this, and is that lasting till the end of the study? Which means if there is more atrial fibrillation in control group, or in this case, remind me where is atrial fibrillation more?
So more in the treatment groups.
More in the tenecteplase group. So if it is more in the tenecteplase group, obviously that means more comorbidity, at least in terms of atrial fibrillation, and therefore they are worse as compared to control group. Similarly, large vessel occlusion, that is more
in the control group, sir.
Control group, right?
Yes, and more
that is why
thrombectomy.
they had more thrombectomy.
Yes, sir.
Right, more thrombectomy. So maybe thrombectomy may have
Better
taken
outcome.
away any disadvantage which control group had. But if they had given us separately it may be in the supplementary, how these 42 patients versus these 18 patients have done. That would be a good thing to look at. It won't take us very far, but at least it will tell us whether difference because of large vessel occlusion was actually neutralized by doing thrombectomy or not. That is one thing which one can look at. But
Yeah,
I think more important point about this study is you did sample size calculation based on 10% difference, right?
Yes, sir.
yes.
And you found direction of effect is same. The Teplage group is doing better, but the difference is 7%.
Yes, sir.
7%.
So 7%. So whatever study you plan, if you plan with 10% difference, but you find less than 10% difference, then your study, I think you have already said that the study becomes underpowered to show statistical significance.
Yes.
And this is a recurrent thing which we have seen, that people, when they plan the study, why do they underpower? They could have kept 5% difference, and then it would have perhaps given more sample size, but they would have had a positive result.
Yes, sir.
Perhaps, we don't know.
Mm.
But why do they do this? Everybody in stroke field or all strokeologists, they know that we have, even with 3 to 4.5 hours, we know the difference is 5%. Why did they power the study for 10%? The reason is that when you are looking at budget of your study, it is going sky high.
Yes.
And you think, or your funder says, no, we can't give you that much fund. This is impossible. So what do? You try to justify your sample size to meet the budget. And therefore you say, okay, let us take, instead of 5%, 7%. Oh, no, it's still too much budget. Make it 10%. Then it is okay. Then you just write, okay, so this is 10% difference, budget is fine, everything is okay, and the study starts. But you have planned for a disaster already, because you know that 10% difference is difficult to achieve, particularly unless you have patients with well-timed onset and 0 to 3 hours. So many of you know 3 to 4.5 hours is still not approved by US FDA. Am I right? Everybody knows, I suppose. US FDA has not approved Teplage for 3 to 4.5 hours. I don't know whether people know this or not.
Yes, sir.
So we guidelines are saying 3 to 4.5 hours. That's why we are doing it. US FDA has not approved yet.
Yes, sir.
And I don't know how many of you have read the paper. ECAS 3 trial was reanalyzed, and it has been reported by Brian Alper. And he has shown that this ECAS 3 trial was not analyzed properly, and all the difference can be explained by baseline differences. I don't know whether you have read that paper. And therefore, 3 to 4.5 hours is still a debatable issue. It is not a clear-cut case. And therefore, a lot of patients here would have been even beyond 4.5 hours. We don't know. 3 to 4.5 hours will be many. More than 4.5 hours, maybe some. Therefore, the study is clearly underpowered. They planned it to see, they took a risk. No, I won't say they planned it. They took a risk. Well, if we find significance, good. If we don't find, at least we will have a paper in the Lancet. So that is the way it happened, I think. And at the end, what can they say? Oh, we didn't find anything. Now, when you write the paper, you can't write anything in favor or against unless you have statistical significance. So you have to write that the studies provides no evidence in favor of tenecteplase to be used in patients with wake-up stroke. That is the statement, which is correct statement. But at the same time, we have to say that this study did not have power to detect a difference to the extent of 7% or 8% or even 9%, what to talk of less than 5%. Now, so what next?
Prasad sir, there are two questions here from the chat box.
Yes.
Dr. Debashish Hota wants to know, does sub-analysis regarding collateral score in multiphase CT can change results? So maybe that's not connected to this study. We should.
Yeah. Well, what I mean, these are subgroup analysis.
Yeah.
And someday we have to talk about subgroup analysis, when to believe a subgroup analysis. This is a recurrent theme, and they do subgroup analysis. One subgroup, they could have done collaterals also, because they have done CT angio in every case. And I will not be surprised if subgroup analysis will appear as a separate paper. That will not mean that you can advocate tenecteplase based on this study, because it will be a post hoc analysis. So therefore, they will have to do another trial. So other trials are going on. We will see when all the results come, and then when somebody does a meta-analysis, we will know whether tenecteplase is useful or not. But I don't know whether they will do study on wake-up patients or not, because it is not easy to get funding for studies when there is a negative trial already. So it is difficult to say, but still people will do meta-analysis of all the trials together, including wake-up trial, and we will see how the difference looks like. My guess is that with this 7% difference, with all the other trials, which ACT trial, for example, when we all combine this in a meta-analysis, it will be in favor of tenecteplase.
So the second question is by Dr. Abhishek Pathak. He says, sir, how about testing the fragility index in this case and its importance?
No, fragility index would is usually done when you have a small trial, much smaller than this. And then you add one event and see how it changes the results. Add another event, means two events, and how it changes the results when there is a positive result. To convert a negative result, how many patients you need, nobody does it, because obviously the study is not advocating tenecteplase. It is not in making any recommendation either for or against tenecteplase. Basically, it is a you can say inconclusive study, or a study which showed no statistical difference, failed to show statistically significant difference because of lack of power. That is all one can say. So when there is a negative trial, then fragility testing is perhaps not indicated. But when there is a positive trial, but it is a small trial, then fragility index is useful, just to see whether actually it is a fragile result.
Thank you, sir.
I think any other question is there?
No, sir. These are the questions.
Yeah, I think Dr. Ila has a question. Ila, do you want to ask directly?
Yeah, question or comments, whatever Dr. Ila may have.
Dr. Ila, you are still around?
Why are we comparing? Why are we comparing twist and wake up? That was the question. I think you have already answered. Hello?
Yeah, I will read the question. Why have we compared excellent outcomes of wake up and twist? That is what is.
No. Comparison between wake up and twist is as I said, is dangerous because that is done on different degree of severity of patients.
That we started, you intervened and started.
Already answered this question, no, sir?
Yes, yes. Yeah, that was a first response from Dr. Prasad.
Any other comments from Dr. Partha and others who are joined from abroad also?
No, let me complete my comments.
Yes, sir. Okay, sir.
So basically, let me summarize my comments. What I'm trying to say is the study is well conducted. I hope there will be some more analysis published in future, but that will not change the primary conclusion of this study. The whole problem which I see is about the power of the study and unfortunate baseline dissimilarity in the prognostic factors. So both worked to disadvantage of tenecteplase, and therefore even point estimate is in favor of tenecteplase, but 95% confidence interval is very wide. So if you look at the 95% confidence interval, that was another point I wanted to make. It goes up to 1.58. Odds ratio goes up to 1.58. So 7% is the point estimate, but it will have wide confidence interval. Again, re-emphasizing that the power of the study is not enough to make any firm conclusions. Now, before you say no effect, let us believe these results and say, no, we didn't find any difference. But remember,
So one small, if I could just intervene. Suppose after increasing this sample size by another 100 as they did here, and they had got a significant result, how would have been our interpretation? This kind of
it can go either way. If we add 100 patients, and we find statistically significant difference in favor of tenecteplase, then one would say that even though tenecteplase group had more comorbidity like atrial fibrillation, still it has superiority over no tenecteplase in wake-up patients. So we would have given in favor of tenecteplase. But we should also keep in mind that adding 100 does not guarantee that direction of effect will remain the same. So who knows, it may have become, the 7% difference may have become 5% or 3% or whatever. Only saving grace in this study is that point estimate. Point estimate is 7% in favor of tenecteplase. If we know the history of this thrombolytic treatment, we know that wake-up stroke is a mix of patients, some who are likely to improve, some who are not likely to benefit from thrombolysis. So obviously, overall, you can't have 10% difference as we see in 0 to 3 hours thrombolysis patient, but you will see something like 5% or maybe little more optimistic sometimes. But this is the main problem with this study, these two factors. Otherwise, I think we cannot dismiss tenecteplase, but this study itself does not provide evidence in favor of tenecteplase. We need meta-analysis, we need more studies before we can conclude anything. So wake-up stroke remains a question mark as of now.
Sir, there is one more
question. I think that is all I have to say.
So there is one more question by Dr. Sanjay Totlani. It says that 2019 modified guidelines have clarified that 3 to 4.5 hours are also eligible for thrombolysis by TPA as per American Heart Association.
Yeah, I think I already said. That is what Sir said.
Yeah, I already said. We are using it because of guidelines. But be sure that US FDA has not yet approved 3 to 4.5 hours.
Yes.
If anybody reads, anybody gets any document which has approval of FDA 3 to 4.5 hours of tenecteplase, please send it to me. So far, I keep searching time to time. It has not approved. But it is offline and it is supported by guidelines.
So there's one more question with Dr. Suchitra Ray, that so overall this trial will still be valid for patients with shorter duration of stroke onset, as majority of wake-up strokes have stroke towards the later times.
Yes, I mean, then of course that it may be true. Only thing is that once you walk into territory, then further questions arise. How many would have had 1 hour before? How many would have had 15 minutes before? How many would have had 2 hours before?
Yes.
And all of these questions cannot be sorted out because we have only CT scan, and therefore that is an area full of conjecture. We cannot do one way or the other. Only thing which you can say is that the direction of effect favors tenecteplase, but because of the power of the study, we did not reach statistical significance. We need more trials to either. And more trials doesn't mean that it will go in favor of tenecteplase. It may go against it also, but we need more trials to firm up our conclusion or to arrive at conclusions. Certainly, we have ongoing trials, but they are not on wake-up trials, as far as I know. Wake-up trial may not happen again. And I told you what will happen is people will do meta-analysis without wake-up trial, with wake-up trial. If results are similar, then you will have recommendation which will be perhaps extended to wake-up trial also. But at this moment, I think we will have to live with uncertainty and use our clinical judgment or perfusion-diffusion mismatch to decide what course of action is better.
Thank you, sir. I think we have exceeded our time. Dr. Sunil, before I conclude, your final comments, and thank Dr. Prasad profusely for his expert comments in this session. And before I conclude, Dr. Sunil, what do you want to say?
Again, thank Dr. Professor for chipping in and making things very clear from a good academic and research clarity. And I also want to thank the team of the young team of neurologists from AIMS Bhubaneswar for bringing up this paper, which produced such lively discussions. And it has been a pleasure to go through this today's paper, which was quite enjoyable. I just wanted to remind you that we will continue to have this first week Monday discussions of new papers. And I would also urge all of you to be on the lookout for interesting papers and to bring it to the notice. You can put the papers in the stroke subsection, and also request Professor Prasad to come more frequently and to to further light up all these proceedings. And I'll ask also those team members who had presented continue to join this monthly exercise and involve in active participation. We had an excellent New Year
opening match.
Opening, yes.
Cyril, I think it's wonderful that we had almost
half century.
Yes, we almost have 50 participants this time. It's wonderful and very exciting. So I think we'll continue this, and one more.
Thank you for inviting me. Thank you.
Thank you, sir. Thank you. And we'll have our stroke subsection midterm conference in the month of July towards the end, and that's a reminder we'll keep on telling. Thank you very much, all the participants, the team from AIMS Bhubaneswar, and if there is, I'm going to say bye-bye to all. Very good night.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Prasad, Dr. Sanjay, Dr. Menka, and the whole team of AIMS Bhubaneswar. Bye then. Good night.
I'm leaving, sir. Okay, sir.
Bye.
Close.
Bye.